All right.
All right, I'm Andy Whitney, the Director of Marketing and Analytics for Teledigm Health. Excited to bring to you the first of one of our educational webinars. We'll have a series of those in the coming months. I'll share a little bit more at the end of the webinar about some of the other upcoming opportunities. With me today, I have Shane Fleming, Chief Development Officer and co-founder of Bryan Telemedicine and Teledigm Health. And so he will introduce Dr. Martin and we will take it away.
Thanks, Andy. Great to be here today. Appreciate everybody taking some time out of their day to spend with us in this great topic. This is part of our strategy in moving some additional contacts out there. We've heard from a lot of our rural health partners that they were interested in engaging our physician resources in more of an educational format. And can't be more excited today than to introduce Dr. Ryan Martin, who's really been instrumental in the development of our pulmonary critical care programs across all of our facilities. And has really been with us, gosh, for over about 7 years now, I think, Dr. Martin. It's been quite a while, but it's been a heck of a program for a lot of our rural hospitals, thousands of patients seen, and can't be more excited to introduce to you Dr. Ryan Martin today for our
Join the meeting.
Session.
All right. Thank you, guys. I really appreciate you putting it together. And I'm happy to share some information about what we do. Some of it is in inpatient and outpatient side of this as a whole, but really talking about a topic from my perspective that's a big part of what we do on a day-over-day basis. You don't really get into pulmonary without thinking you're going to take care of COPD patients. So obviously, that is something we all do. And everybody has their opinions and preferences. This is obviously one of my favorite processes going forward here. As with most things, a lot of this comes down to quality metrics and what are we working towards in a lot of instances. But when we start and we talk about COPD, the best way to start with this is to actually look at just as a whole, what is COPD? Why does it matter and why do we care? And probably the best place to start is with this. First line tells you a lot. And this is actually from the Global Organization of Lung Disease. This is actually kind of in their wheelhouse, how they talk about it. But this data is where I get some of the slide information on. So it is one of the top 3 causes of death worldwide right now. So if you think about cardiovascular causes, cancer, and COPD. So it's moved up a little bit. It used to be in about the 4th slot, and it's slid ahead of stroke. 90% of the deaths in COPD will occur in our low and middle income countries. So it's, as much as we see it in the United States, it's more prevalent outside of our country. And it's very much a heterogeneous disease. And I know that this is something that is experienced far and wide, as far as everybody else, what we see plenty of times where we'll see patients with maybe they have dyspnea, maybe they have wheezing, maybe they have sputum production or exacerbations, the bronchitis,
Join the meeting.
emphysema. To be honest with you, you may see people with all of these, with one of these, with very little of it. Cigarette smoking is our primary impetus for why we have this disease. That said, you may have patients who smoked, 15 to 20 pack years and have absolutely abysmal pulmonary function. And you may have somebody who has smoked, 2 packs a day for 60 years, and they may have minimal obstruction and hardly any disease. So it's a very heterogeneous disease. We do not fully understand why it is so heterogeneous in certain patient populations versus others, except for a few instances, which I'll talk about up on this next slide. So the primary is obviously tobacco smoke. So we know that when we see cigarette smoke, that is the primary impetus. We go by pack years. So it's a pack a day for X number of years. And what does that look like? The bare minimum threshold is 10 pack years to have somebody that we believe developed COPD. There is the outdoor or household pollution. So if you think about, people who are working, depending upon where they work. But you can have, firemen that have a lot of exposures, and unintentional exposures, especially if they are not wearing masks. Or if you think about interior, specifically this fourth line down, the heating and cooking oils, we can see that from poorly ventilated. So really, that's not something we see very much in the Western world. But if you look back, historically, and I always find some of the history lessons are fun. But if you go back and look at the industrial age or Iron Age in Europe, there were quite a few patients with emphysema, COPD, that were just, poorly ventilated kitchens and just cooking indoors that was causing problems. We do know that we have some issues reaching lung maturity if you have this bottom row. So you might see low birth weight or the premature patients, infants, or multiple childhood respiratory tract infections. So that's one of the things that you'll see that is a predisposition to people maybe having obstructive lung disease as they age. This is some of the cause. I'll be honest, that is not something we see all that often, but it is out there and it does exist. And then obviously the alpha-1 antitrypsin. So that is one of the few places where we definitively know, yes, there is a disease. There's a disease state that we see. It is something that really honestly should be checked. It's actually a free test. And if you check it on your COPD patients the first time you see them, you never have to worry about, did I do it? It's already in there somewhere. I always like to look at this in terms of, can you see it or can you hear it? What walks in your door, and what walks in through either the hospital or through the clinic door. But it's kind of a yes and no. In a lot of instances, it is a clinical diagnosis. Somebody may be coming in to see you. Maybe they have some dyspnea. So you have to get why are you in the clinic or why are you in the emergency room? But you don't always get to see it coming. You have to ask the right questions. And from there, some of it comes in on tests, but I do like to have a comment. I didn't put PFT on this, and that's because in about 70% of the cases of COPD, we don't have a pulmonary function test. The diagnostic criteria is actually not present in about 70% of cases. So that's a plug I have right now to say, if you're suspicious of it, the best thing to do is to actually start by testing people and see where they are. It's a functional test. It does change over time, but it is always something that you can fall back on and rely on. So things that you can see in somebody who maybe isn't telling you all the information or giving you stuff up front. And the hyperinflation on a chest X-ray is the absolute first and foremost. That's an objective finding you can see. That's the flattened diaphragm, the barrel chesting, the retrosternal airspace, that space between the sternum and the chest wall. You might see that increase there. You might see somebody, yes, they may be wheezing. Yes, they may have that pursed lip breathing. So you might see somebody coming in there and kind of doing that just slow blowing out the candle breathing when they're there. That may be some of the dead giveaways on that as well. And then, there's a number of times that we see charts that say COPD on it, but in terms of what we see, not everybody has COPD that's wheezing. There's
Join the meeting.
Oh, there is, there's the asthmatics, there's the cardiogenic wheezing, there is an obstructed airway, meaning foreign body, especially if it's unilateral. So there's a whole bunch of things that go into this. You may or may not always see that. I always like to look at that. Then just the simple diagnostic criteria. And sometimes I find it's really worthwhile to just start by saying, what is the absolute bare minimum, or what is the threshold where we say, yes, this meets criteria? So you typically have to have at least a 10-pack-year history of tobacco abuse. So, we expect there to be that degree of basically inhalant or injury with an FEV1 to FBC ratio post-bronchodilator of less than 0.7. So we do expect to see that happen. You may or may not see the structural processes, specifically emphysema. It may not always be there. And in fact, even in some patients who have fairly significant obstruction, you may not see the emphysema. They're the symptoms. So again, you should be seeing something in terms of symptoms: shortness of breath, wheezing, cough, sputum production. And then again, you can look down this prism. This is preserved ratio and impaired spirometry. This is actually fairly common, and what I would tell you is this is kind of that pre-COPD individual. So in a lot of instances, they'll have their spirometry that may be, call it on FEV1 about 75 or 85% of predicted, both FEV1 and FVC, and it may be above that 70% ratio. But when you look at the lung volumes, they may have that air trapping. So when you look at your total lung capacity or residual volume, you'll see that those values are significantly elevated. So that's what that means, is that's the ratio is still preserved. They haven't developed significant obstruction, but they do have the changes that are already developing. So it's more of a pre-COPD diagnosis. And this is what I'm talking about here is this 30% of patients with moderate to severe COPD, only 30% have had a spirometry done. And that would be gold 2 or worse. Or if you use ATS criteria, you're going to be looking at patients with FEV1s less than 70%. So that's in that moderate severity category. I will make a little comment here about what do I concern myself, whether you use ATS or you use gold criteria. To be honest, all I would say is you pick one criteria and stick to that criteria for all your patients. That way we have we're talking the same language when we see them over and over. Differentiating this from asthma. Sometimes that can be difficult. Again, it's generally historical. So the patient who is a never smoker, if they don't, if they aren't a chef, if they're not cooking with oils, if they're not standing over something that's flame or smoke or inhalant specific, the likelihood is that it's not driven by a COPD process. But you would also obviously compare that to imaging. Asthmatics will have air trapping. That is a thing that we see fairly routinely with asthmatics, especially if it's untreated for long term. So sometimes that CT scan plays a role. They also tend to have the variable airflow obstruction. So that will be your exercise-induced asthmatics. This will be somebody who should have generally normal spirometry, but what they will have is that exacerbation. They'll have that trigger that would cause them to have the airflow obstruction. That's a very common finding. Asthmatics will have more trouble at night. They'll have a lot of times that atopic presentations of the allergies or eczema. There is a very strong familial component to asthma, whereas in COPD, it's not so much the history as much as it is the exposure. So there's usually that differentiator, and then again, kind of the general lack of emphysema on the CT scan. So when we've looked at this, and this is always kind of a fascinating slide, and this is one of those things that I always like to just slow down and appreciate. In all the times that we've had to identify and treat COPD, we've known COPD and emphysema have been a problem dating back into the 50s and 60s pretty consistently. We've had very limited treatments for many years, actually. In all that time, we've tried several different things, but there have only been 2 things ever previously that have really shown to improve mortality. And the number one is tobacco cessation. The interesting part on this is that tobacco cessation is really out of all of our hands. For as much as we know how to do as a medical community, one of the 2 things that we know reduces mortality, UI and everybody else on this, really, that's out of our hands. Once somebody leaves the clinic or once they leave the hospital, we don't have control over what they do, whether they stop smoking or not. Even if we're very convincing, they may have some problems. So what you'll see there is there's very clear benefit. It shows up in the Fletcher curve. I didn't put a Fletcher curve in here, but that's that curve that shows where lung function begins. You have a certain amount when you're born, your lung function peaks around the age of 30 to 35. And then we gradually lose that little bit of lung function the rest of our lives. You'll see that Fletcher curve normalizes to some extent after people will stop smoking. This benefit is both in longevity and quality of life. It's a very significant benefit to our patients. And again, it's tough to see that because that's something that as much as we try, it's out of our hands. The other thing that we have is oxygen. And we've known for quite some time that oxygen will add to lifespan. It clearly adds to length of life. But this one is a little bit different. It does have an impact on quality of life. So, and it impacts it both positively and negatively. So I'm going to skip down to this bottom point here and talk about that, what I mean by it. So there's a positive impact on quality of life, and that people do breathe a little bit better. They breathe a little bit easier. They have a little bit less shortness of breath. That said, carrying around a tank, an oxygen tank, really is something that is troublesome. I have a very hard time with certain patients. They look at it and they call it vanity. At least they're honest about it, but they don't necessarily want to drag around an oxygen tank. And if you think about it, in a lot of instances, this is something that we are sending a patient home from the hospital with oxygen. And that is the equivalent of a new parent getting in the car and somebody putting that car seat in the back seat for the first time and shutting the door. They now own that, and it's a instantaneous life change in a lot of cases for patients. So sometimes that's actually hard to deal with, even though you can convince somebody that it is useful and helpful, but it is actually problematic. It's hard to get people to use oxygen in certain instances. So, we try, and I will tell you, 80 to 85% of the time, I would say patients will eventually come around to using their oxygen pretty reliably, but there are a few stubborn folks out there that just don't like it and don't want to use it. Don't give up on them. Just keep trying to convince them that's the best we can do there. I did leave down here a line as possibly a third opportunity, and I'm going to probably talk about this third opportunity at the very end of our talk. Specifically, it is a medication. It is some medication. It appears to be more class effect on medication. We can talk about that at the end. So I'm going to talk about a COPD exacerbation, and really what happens to our patients when we have that COPD exacerbation, and really why does this matter? And to be honest with you, I'm going to suggest that as a society on this one, I don't know that we've been thinking about our COPD patients and their treatment necessarily in the right light for quite some time. We know that a heart attack is a bad thing. We've known for years heart attacks are a bad thing. And if you look right at this right here, in the first 5 years after somebody has an MI, what you're seeing is a 36 to 47% mortality rate. And that's for patients 45 years and older. That's AHA data. Nobody has to be told that a heart attack is a bad thing. COPD exacerbations are interesting in that I think they're fairly common. And in terms of data sets, I don't know that we've had a lot of great data until much more recently with regard to what's actually happening to our patients after that exacerbation. So there's two studies that I'm going to talk about on this one. The first one is it's a Canadian cohort. This is a little bit of a history lesson, but this study, it's a 50% mortality at 3.6 years. If you look at this Canadian cohort, this study was done from 1990 until 2005, and patients were followed until late in 2007. And basically, it's a retrospective meta-analysis type study. Basically, all they looked at is said, did you have a COPD exacerbation and did you die? It wasn't a complicated study. It wasn't, they weren't doing interventions. They were just trying to get a sense of what was happening. And this is just fascinating to look at that number. That's really, really striking. It's really significant. The mortality curve there really is tough. It didn't take into account severity of illness or severity of disease. It just looked at exacerbation and death. There's a United States cohort study. It's different. The mortality here, this is a 6 years at that point, and then it's 43 to 56%. And this was after 1 or 2 severe exacerbations. So basically we're looking at, and I should clarify, they were hospitalizations for both. So they were basically severe exacerbations required hospitalization. But that first hospitalization, that's a big marker for mortality. I do hit home on that because I think that's really probably one of the things we need to be focusing in on is that exacerbation. It really does seem to have a significant mortality implication for our patients. So to comment on the two studies and why the United States data looks better than the Canadians, 1990 to about 2007, the drug cabinet for COPD was fairly limited. You would have had albuterol, you would have had ipratropium, Robenal was out in the earlier part of this, so glycopyrrolate nebulized. but really it was a steroid and theophylline. We had very limited treatments at that point in time. We didn't have a lot of therapies that were viable. So basically what I think you're seeing is when you look at the Intermountain Health study, this one is from 2009 to 2014, 2015. What you're looking at is the difference between basically short-acting therapies or, therapeutic window monitoring of theophylline type of thing versus a whole cabinet full now of long-acting medications. It's a significant difference in terms of what I think it is. So I do think there's some implications there based upon the history lesson alone. One thing I will talk about this Canadian study, also just to kind of give some reference to the magnitude of the study, was 73,000 patients. That's not a small number. So when you look at 73,000 patients that had a COPD exacerbation, 36,000 of those patients were deceased within 3 years of when they had their exacerbation. The Intermountain Health study also not as long, similar in terms of its structure, but this was still about 18,000 patients. So these were not small studies. This was a significant amount of patients that had these complications, had this process. So I think you can make some pretty solid inferences that the data here, it is at least indicative of a significant problem. The exacerbations, this is, frame that conversation around an exacerbation. What exactly is an exacerbation? So I'm going to make it fairly straightforward. The mild exacerbation, that's a patient who uses their albuterol inhaler quite a bit more frequently, albuterol or Xopenex, whatever they have for their rapid acting. And that's somebody who's typically not coming into clinic. And so I use the comment there, makes the news. Basically, you have to pull this out of them. So if you think about notifications on your phone, there's the push notifications. That's the stuff that winds up dinging your phone versus the stuff you have to pull. You have to basically open the app. You have to talk to this person. You have to get their history. You have to understand what they're using. You have to usually figure these out on your own. Mild exacerbations, due to the heterogeneity of this and the ability to really get a lot of good, solid information, we don't have a lot of information about what a mild exacerbation does to patients. But you can contrast that to the moderates. So the moderate exacerbation, the way I would describe it, this is a person who's having symptoms. They're going to call. They need to be seen in clinic. They've got an increase in some symptom, whether that's dyspnea, cough, sputum production. This is somebody who's having a problem and they want some help. So this one is somebody who's coming in to see you. I usually use the clinic visit versus the ER doors as the differentiators between the moderate and severe exacerbations. Now, that doesn't mean that every severe exacerbation always goes to the ER. There are certainly severe exacerbations that wind up in clinic, and those patients because you usually are making a phone call to get them into the hospital and get them in bed and have them spend the night there or get them to the ER. And that doesn't mean that every ER visit obviously is a severe exacerbation. There's plenty of people who use the ER as primary care. So you may have somebody who's got a mild, more of a moderate exacerbation that you're able to sort of, treat and street, as opposed to having them stay the night. So there's some minor distinctions, but that's usually the simplest way to do it. You're typically able to manage that moderate as an outpatient though. That severe exacerbation, this is somebody who acute onset shortness of breath, usually quite breathless, a lot of chest tightness, maybe hypoxemic, and oftentimes they are. But usually that's somebody who's going to require that hospital stay. So that's usually the differentiating factor for what I look at for those. And why this matters is this next slide. So the impact of that exacerbation. So this first part right here, this 21%, if you have a moderate exacerbation, you're at an increased risk of a severe exacerbation. Basically 1 in 5 of our moderates are essentially coming back with a severe exacerbation. We're seeing a significant tick up in that risk of the severe exacerbation. If you look at our patients who've had that severe exacerbation, what happens to them? I mean, we all know the mortality for our COPD patients. They're not dying all of acute and chronic or acute on chronic hypoxic or hypercapnic respiratory failure. What they're usually dying from is cardiovascular events. So you're seeing that tenfold increased risk of cardiovascular disease, whether that's a stroke or an MI. We're seeing a significant jump in that patient population who are having those set of symptoms right there. So we're really seeing that jump in the symptoms thereafter. What does the impact of the exacerbation have on our lung function? So this is what you'll see here. The numbers are fairly small, and I'll couch this in why I think this is worthwhile just taking a look at. So the line here is pretty self-explanatory. In the weeks preceding an exacerbation, this is 8 weeks pre and 8 weeks post, but you'll start to see people have that dip in their lung function around an exacerbation, and then they return, but they seem to return to a lower baseline level. So if you're measuring this in liters, what you're seeing is that you're seeing only about a 30 cc difference in lung function from pre-exacerbation to post-exacerbation. And to be honest, that's going to be below the threshold where you would say there is a significant difference. It's going to be below the threshold where you would look at this and say, you look at it from a numbers standpoint and say, how significant is this? But when you are looking at an exacerbation, what I would tell you is this: when we go back, and I referenced that Fletcher curve before, the typical adult human will lose on average 20 to 40 cc's of lung function per year without an obstructive lung disease. So on average, you figure if you'll lose about 20 cc's per year. Somebody who has their COPD exacerbation essentially lost a year's worth of lung function in an instant. So it does appear to have a significant issue to them in terms of what their lung function lost. And realistically, the more severe the lung function impairment, the more likely this is to have an impact on them down the road. In terms of our treatments, I am going to jump into this a little bit. So we kind of know the majority of our treatment for COPD is inhaler-based therapy. It's really driven by 3 different classes of medications for the most part for the inhaler therapies as well. And the GOLD guidelines that came out this past year in 2023 really seem to have taken a stance on the inhaler or the inhaled corticosteroid class as a whole. That I don't necessarily think is the correct stance. They are basically lumping every single ICS in as a risk of pneumonia, and there's theoretically about a 4% risk in the increase of pneumonia. But the interesting part in that is that not all ICS is the same, and there is a slide I'm going to show in just a moment that actually talks about this. So they really focused in on using that LAMA-LABA. The LAMA-LABA, it's the dual bronchodilator class of medications. And when you're looking at that LAMA-LABA as the dual bronchodilator class, they seem to focus in on 2 things. One was FEV1, and the other was they wanted to drive down your risk of having a pneumonia. They didn't necessarily look at what I would consider probably the bigger item, or the elephant in the room, which was the all-cause mortality, which is something that we'll again address here in just a moment. But not all ICS is the same. And the treatment options, they really focused in on kind of throwing out the ICS LABA class in our patient population with COPD, and I don't necessarily agree with that stance. This is a slide that actually talks about budesonide versus fluticasone specifically. So if you look at your risk associated with budesonide and you look at your risk associated with fluticasone for the risk of pneumonia, there are 10 different studies that are listed here. And really, in about 60% of these, it's pretty clear that there is a benefit if you actually stay or use budesonide-based therapy. And I get where GOLD is going at, and that they don't like to necessarily pick sides in medications, but this is partly what they were doing with this, is they're kind of ignoring some data sets that suggest there is potential benefit to still use the inhaled corticosteroid and avoidance of our avoidance of the class as a whole. So there's some talk in that, and that's why we look at this. You've got your LAMA, your LABA, and your ICS, and those triple therapy patients and what that looks like. And that's why they've done it this way in this past iteration of it, unless you've had exacerbations. That's one of the treatment topics I'm going to go into. Then this next one here is really just kind of the opportunity. So this is another one that this is another different study. This was actually published as more of an abstract. The study isn't out as of yet. Will be coming out fairly soon. But it's a study that was completed as a retrospective. It was chart reviewed only. So this was not, there's no double blinded. There's no placebo group. This is study that was done, and what the goal of the study was to identify patients who had COPD who were hospitalized with COPD exacerbations. Were they consulted by pulmonary or were they not consulted by pulmonary? And the primary endpoint was length of stay, but they had the secondary endpoint of the readmission rate at 90 days. And then they had again, so I've gone through this, but there's consultation or no consultation, no control group, and it's not blinded. One of the things they did find is in the group where the pulmonary consultation was utilized, those patients were more likely than not to be hypoxemic. And the findings on this study are interesting. So in the length of stay, the pulmonary group on average is 4.16 days. The length of stay in the primary care internist group was 4.21 days. So there's really no significant difference there. But what they're finding was that I found pretty interesting, and this was the readmission rate. And really, we all know this, we're all measured in how we do. Readmission rate is how CMS likes to look at us as a whole, as all physicians, as a society. And we're all held to a certain standard. And what they're finding at the 90-day readmission rate, and I find it interesting that they went to 90 days, but it was a 90-day readmission rate. So in the pulmonary group, this patient cohort was 30.6% likely to readmit within 90 days. And in the primary care internist group, it was 57.15% at the 90 days. The difference is probably most likely in the follow-up and how common, COPD exacerbations, unfortunately, are really, really common. It is something that we see all the time. And it is the severity of the illness, the severity of the disease, I think, and the significance of the COPD exacerbation, what that does. I think that data, those slides that I talked about for mortality data, I don't think those really received their due in terms of medical publications and what was really out there. So the follow-up in a pulmonologist, and I can tell you this is typical in our practice, we have people, we make every attempt to get people in within 2 weeks after their hospital stay. And I think this is pretty telling, because that's what the literature would suggest. In the pulmonologist group, we're seeing people back in about 23 days, as opposed to in the primary care group, maybe 65 days. That's a pretty significant difference. And I think some of that is just, again, that data point about what's that exacerbation doing to the patient, and what is that really manifesting as. So those are some of the topics there. Key takeaways on this one, as far as what I look at when I frame this. You'll notice I didn't talk a lot about FEV1 in this. So what matters more? Obviously, the FEV1 is a symptomatic measure. When you look at your patients, if you can get about 100 cc's of lung function back with the medication, they will typically feel better. And that can be measured usually in the SGRQ, or St. George's Respiratory Questionnaire. So you'll see a benefit in terms of how they feel. But realistically, the thing that seems to actually be that marker on our patients is that COPD exacerbation. That really does, that severe exacerbation really seems to be the driving factor for that disease progression. And that overall, just that secondary cascade of events, the stroke, the MI, the rehospitalization, those things all seem to be predicated around that exacerbation, really not as much as the FEV1. That's really one of the biggest differences, I would say, coming forward. The risk of pneumonia, the interesting part in that risk of pneumonia, and I didn't really talk about that as much, but it's my bottom line here is those medication adjustments. If you look at that adjustment that we talk about, obviously we know tobacco cessation is going to be key on this. And again, it's out of our control. Oxygen, again, as much as we would like to say we can prescribe oxygen, people are going to be adherent to it. Realistically, that's a difficult one, and it needs to be checked fairly routinely. And medications. Now, I will say this: the medications, there are some studies that are coming out now. This is mentioned in the GOLD guidelines, the last iteration of it. It's not given, I think, a lot of data as of yet, or not given a lot of credence as of yet. I think they're waiting for more data on it. But the long and short of it is there are triple inhalers. And there's some data that suggests an all-cause mortality benefit by using a triple inhaler. And it seems to be that it's going to have another tool in our arsenal that may be a morbidity or mortality reduction agent. And then you kind of look at that middle portion of the slide where I talk about my strategies here. And so what does that look like? And realistically, that exacerbation really seems to be a big deal. And when you start thinking about practically, what are we going to do with patients and how are we going to handle them, and wanting to do our best for our patients, I think the big thing there is, how do we handle the inpatient side of it? And I think, in the grand scheme of things, a lot of the inpatient side is in some ways fairly straightforward in terms of the treatment part, but really it's getting them out of the hospital. It's getting them out of the hospital with the right utilities, such as whether or not they need oxygen or whether they need pulmonary rehab or pulmonary PT, plus or minus the correct medications, and then getting them back into the clinic. In a lot of instances, these are going to be fairly frail individuals if they're starting to have their exacerbations. So getting our patients from the inpatient realm to the outpatient realm and keeping them back in that outpatient realm is a big part of this. It's a lot of follow-up, and it really speaks to how do you get people out of the hospital? How do you get people out of the hospital effectively? And then once they're out, we really want to keep them out of the hospital as much as possible. So that leads me into the questions section of this. I think that was about 800 words a minute. So I'm going to slow down and answer questions here.
Yep, I got a couple questions for you, Dr. Martin.
All right.
First of all, what are your thoughts about the impact of secondary inhalation of cigarette smoke and COPD?
Okay, so secondary inhalation of smoke and COPD. So there's two thoughts on this. One of which is the secondary inhalation of smoke. Anybody who is sensitized, so sensitized airways are prone to bronchospasm. Secondary smoke, they are going to have some symptoms associated with it. So you will see people have, a bronchospasm event. If you think about specifically asthma, kids who are around parents who smoke are more susceptible to developing asthma. We've known that. So we know that there's some sensitization of the airways where people are more, patients are more likely to have some wheezing or side effects of that. In terms of development of COPD or emphysema, there's not a lot of clear data on whether or not we see a lot of actual emphysema. But in terms of symptoms, I do think what you'll see is more of a bronchospasm or irritable airways, but not necessarily the emphysema. Especially as you look at kind of societally now, we've moved away from indoor smoking. So as a whole, there are very few places aside from Las Vegas where people are smoking indoors on a chronic basis.
Great, thank you. Another question was, you talked about the mild exacerbation not making the news. How can a primary care provider maybe detect some of those a little bit easier and start treatment before it becomes a moderate or severe exacerbation?
Great question. So this is, and I know I live in the same world where everybody else does, right? I'm seeing patients throughout the day. So you have about a 15-minute window. And in a lot of instances, you have to figure out what questions are going to be poignant. How do I get to the point quickly? I always start with patients who I know have COPD. How have you been? Have you been hospitalized for your COPD? Have you had to go to the emergency room? When was the last time you had to have a steroid? How often are you using your rescue inhaler? And it's a simple question. It's like, well, how many? And then sometimes I go, oh, I don't know, not very much. That's a really common response. Like, how many times have you used it? Did you use it today? No. How many times have you used it in the last couple of days? Not at all. How many times would you say you use it per week? Just kind of tease that out, because you'll start to find those people who are starting to say, oh, I'm using it, 2 or 3 times a day. I've been using it that way for about 3 or 4 days in a row. That's a very common finding. I'm sure, across state of Nebraska, across the upper plains, very, very common for us to have somebody with fires and that smoke blows through. And so you might see somebody coming in, and if they're an asthmatic or they have COPD, and that doesn't matter to me what obstructive lung disease they have, I ask the question of them every time. So I think that's a great way to get at that part of it, because again, it does not, you have to have that set of questions you like to ask. Once you've asked it enough time, it becomes muscle memory and just becomes part of how you interview your patient.
Yeah, great, thank you. Another question from primary care: Is the in-office spirometry acceptable for COPD as a screening and diagnosis tool for 10-pack a year plus smokers, or are formal PFTs really more recommended?
Excellent question. It's absolutely acceptable for diagnosis of COPD. The only problem you're going to run into with it is it's spirometry, so it's limited. You don't have the lung volumes, the bronchodilator challenge, and you don't have the DLCO. So you're not going to catch DLCO impairments that way. You're not going to catch the hyperinflation, and you're not going to catch the reversibility. But that's all fine. It still is a great place to start. And if you can get in-office spirometry, number one, it's reimbursed, so it's worthwhile to do. And number two, it just gives you something objective you can hang your hat on. And in virtually every instance, I'm always going to say you got to have something to go off of. So if you've got it, use it.
Great, thank you. Another question, this is on the inpatient side. What are you recommending for dosing of steroids as an inpatient? Staying with Solumedrol or transitioning to prednisone sooner?
Okay, so this is in the art of medicine. This is where I would if you ask 10 of us, and there's actually 13 of us, but you might get, 13 out of us, you might probably get 10 different answers. So in terms of what you use, there are trials out there. There's a trial out there called the REDUCE trial, and the concept was how much steroid is absolutely necessary. And realistically, it is, as much as you'd love to say that the answer is cut and dried and you can get by with less steroid, the fact of the matter is the patient in front of you, studies are always like this, right? That you get all this data, you get the N of, call it 10,000, but the problem you run into is when it's an N of 1, because if I'm the person in bed, I don't really care what 9,999 other people had. I just need to make sure that I feel better. And that's really how your patients are going to look at it too. So they're going to tell you. Generally speaking, I like to use the IV steroids for that quick burst, at least first 24 hours. I would tell you more often than not, it's around 48 hours when you can usually safely make that transition. But it's got to be, it's patient specific, it's patient driven. And if you look at why, and I'll say this, why our practice model is to get that patient with the exacerbation in within 2 weeks. The reason why is they come off their steroids around that 2-week time. So if we give them a steroid burst and taper, that's anywhere from an 8 to 12-day taper. In a lot of instances, you need to be seeing them because those patients who felt great on prednisone have come off of it by the time we get back to seeing them. And when they come back in to see you, they say, I'm just not feeling as good anymore. Well, they finished their doxy or Zithromax or their antibiotic, they've completed their steroid taper, and they're starting to wind back down again. That's where that secondary appointment really makes a huge difference in preventing that readmission. You can't prevent them all. I'd love to say you can prevent them all, but you can catch a lot of those people in that sort of fall down period. As far as answering on the inpatient side, as soon as people are breathing comfortably, as soon as people are not tachypnic, and they're not necessarily pursed-lip breathing nonstop, that's when I usually start to make that transition. But that's not really a quantifiable difference. And there's going to be inter-operator dependence, right? So it doesn't matter who happens to walk in, there's going to be who's making the decision. So it's different. I wish I could say it was not.
Sure. All right, one last question. With COPD exacerbation and admission, how reliable is procalcitonin in determining the antibiotic course of care?
It's similar. The things that seem to throw off the procalcitonin specifically, renal impairment and active cancer diagnosis. Those seem to make it a little bit less reliable, but in terms of our antibiotic duration for our COPD patients, it really matters more, I think, if there's pneumonia, but for an exacerbation, a lot of times that procal won't be up to begin with. So it's the concept of the underlying bronchitis or bronchiolitis that comes along with it. And there is benefit in using an antibiotic, but it is reliable in terms of what the number is in our COPD specific patients.
Great, thank you. Well, thank you, Dr. Martin. Thank you, everyone. Just a couple of housekeeping notes before we wrap up. This is the first in a series of educational webinars that we're going to host over the next several months. We do have a couple coming up, and watch your emails. We'll be sending out information on how to register for those. Coming up is transitions of care with comprehensive pharmacy services. And then a little bit later in the year, some discussion about technology, security, and all the fun stuff that the IT folks have to put up with. And that was with our partners at Five Nines. So thank you everyone for joining today. We're pleased to see so many people interested, and we will see you in a few months.